All right. So cold injuries. Basically, peripheral cord injuries are. We're talking about hypothermia in general, right? So peripheral cord injuries start with chilblains, trench foot, frostbite. These are all surgical emergencies and stuff like that. That doesn't affect us that much. Hypothermia, core temperature below 35. Remember that number very well. 35 is where you start seeing, you start defining it as hypothermia. Death triad, people used to be like, this is like a cookbook kind of thing. They tell you if you have hypotension and hypothermia and coagulopathy in a patient, especially unintentionally, chances are you will have death. So that's the death triad. I'm gonna get this out of the way before everybody keeps raising their hand and say, Osborne wave, Osborne wave. Okay, that's the Osborne wave. Get out of the system. We don't care about it anymore. It happens about 34 degrees Celsius. This table is very important. It comes from the books, old books, and it became even more important when we did more hypothermia because we started, using it and actually maybe modifying it a little bit. So mild hypothermia starts about 35 degrees, like we talked before, and for mild hypothermia you see cold diuresis and maximum shivering. That's why the recovery room is the shivering capital of the world. There's a lot of shivering in a recovery room for that reason and for other reasons too. But also at 35 degrees, unexplainedly, you have a lot of diuresis. We don't know why, but people say, oh, the loop of Henle, the cells get, the reabsorption of water is impaired and all of these things. About 34 degrees, you start seeing ataxia, poor judgment, and Osborne wave. In about 32 degrees Celsius, you start seeing amnesia, difficulty to measure blood pressure. Less than 32, you start going into moderate hypothermia, which basically starts with stupor, dilated pupils. Okay, we've seen dilated pupils even in this area here. What we mean by dilated pupil here at 31.6 degrees is that both of them are dilated and probably fixed. So when we were doing a lot of hypothermia, you see about maybe 33 degrees, 34 degrees, you see dilated pupils, but they're not equal. Or some of them are, they could be responsive to light still and stuff like that. And we send so many people for CAT scan and they're all negative. Just because of the dilated pupil that is not equal. Shivering ceases about 30 degrees, 0.5. So between 35 and 30.5, that's the shivering. Below that, there's no more shivering. And that's important when we talk about the thermosuit. About 30 degrees, that's exactly in the middle of the table if you look at it, and it actually that's the start of serious reactions now, or serious problems that are gonna happen due to hypothermia. So the benchmark, or if you will, the red line that you should not cross is the 30 degrees Celsius in hypothermia, because you start seeing cardiac arrhythmia and inactivation of insulin. And again, total inactivation of insulin about 30 degrees. Above that, there's varying degree of inactivation of insulins. We had people here, the maximum that we've used was 999 units per hour. We've used it again last week, right? Of insulin, because the insulin is not working. You just have to keep giving more insulin. In degrees here, like 33, 34. When you reach here, it's probably you'd be using more. And the only reason we stopped at 999 is that that's the maximum for the pump. You didn't want to use 2 pumps.
Is it that the actual insulin isn't effective, or the tissues aren't utilized?
Oh no, the insulin itself doesn't work. Stops working. Insulin also stops working with acidosis. Acidosis stops. 27.8. That's loss of consciousness and ventricular fibrillation. So about 28 degrees or so, you start seeing the loss of consciousness spontaneously and ventricular fibrillation. And right now, we have at least 50 people in the United States, or maybe 100 people in the United States that are actually having ventricular fibrillation due to cold. Where are they? Scranton? No. Huh? Where are they, you think?
Alaska.
Nope. In the cardiac ORs, right? So everybody who's having cabbage, they start, they establish the circulation, they get CPB, now everything is circulating, everything's fine, cool the temperature, decrease, and now the patient starts to either you know, they either catch him before or he goes into ventricular fibrillation, and they quickly give him a cardioplegia solution immediately after that, so he stops, like the heart has become asystolic. Cardioplegia solution is cold, slush, ice, and lots of potassium. It makes the heart just stop. But it happens very, very frequently in the cardiac OR, almost predictably at this temperature. And that's why when we warm people that are less than 27 degrees, the idiotic way of warming is just put the blanket, talk to the physician, you know, get the order, talk to the ICU, talk to this, talk to that, and then the patient is creeping up and lingering between these two temperatures here, between 28 and 30. That's the worst you can do for this patient. Just keep them cold if you're not ready, get everything on top of them, and then warm like as fast as you can to pass through these degrees fast, because otherwise they're gonna have VFib. 26, loss of muscle reflexes, and then profound hypothermia, that's less than 25.5, the acid-base disturbances, loss of pain. 24, pulmonary edema. 23, loss of corneal reflex, and then heart standstill, or asystole is about maybe 16.6 or something like that. The important part here is that what are we going to do for each one of those? So for mild hypothermia, again, insulate, warming blankets, warm IV fluid, warm bath, you know, all of these things, it's fine until like 34 degrees. Moderate hypothermia, then add to that airway gas warming. That's actually very, very effective because you have the huge network of capillaries and bronchi and alveoli. Colonic irrigation, don't do that for me, you can do it for somebody else. And peritoneal dialysis, right? If somebody has a peritoneal dialysis catheter, don't think about it twice. Get the dialysate, 5 liters, warm it, and just put it inside the patient. That'll warm very, very quickly. If somebody has a dialysis catheter, dialyze him, and dialyze him at 37 degrees. He'll be very quickly warm, and stuff like that. And then profound hypothermia, which starts as what? If you remember from the table here, 25.5. If you're let's say 26. If you're below 26, you recommended by the books, right? Nobody does that. It's important. Recommended to actually warm them using cardiopulmonary bypass, like a bypass. So talk to your thoracic surgeon or cardiac surgeon and say, I need a fem-fem access or fem-fem bypass.
So can they do ECMO?
Well, yeah, it's not really. It doesn't need anything other than just circulating the blood. So you don't have to crack the chest. You don't have to do anything.
Yeah.
Just fem-fem arterial bypass, and they run on the bypass machine. Whether they do the warming on the bypass machine or you do the warming in the machine, just circulate the blood, whatever it is, so it doesn't go into VFib. Or if he goes to VFib, we have already a circulation, right? If they say no, then document it very well in the chart that they didn't want to do it. Most of the time, sometimes they don't do it for older people and stuff like that. If you have that situation, or if you're in a hospital that doesn't have bypass, just warm as fast as you can. Just get everybody ready, warm the room temperature, you know, everything, and just go. All right. Load them with amiodarone also before, if they are, or lidocaine. If you think that they're gonna go into like lower temperature than 25. The lowest reported infant survival from accidental hypothermia is 14 degrees Celsius, and the lowest reported adult survival from accidental hypothermia is 9 degrees Celsius. Yeah. That comes from our friends in Siberia, right? That's why they call it never cold and dead. It's warm and dead. So when somebody shows up in the ER and it's cold, never pronounce them, because unless you want your name to go on a paper, just warm them up first and then pronounce them dead. Have you ever tried to warm up a patient who is dead? Like he's cold and dead, you want to pronounce him? Extremely difficult. Extremely difficult. There's no circulation. You're gonna have to like. So and what temperature? Nobody tell you really what temperature you should warm above. So I just look at this table and come up with my own temperature. The temperature is gonna be 30, right? Because what is the loss of consciousness? 27.8. So if I get the patient above 30 and he's still dead, then he's not gonna wake up, right? So if he's 26 and is in cardiac arrest or whatever, we have to warm him up. Very difficult to warm. So and nobody also told us how do you continue CPR until the patient is warm? I wouldn't, because that's gonna be hours, and the whole staff is gonna be unless you have the Lucas, but then you gotta bring the Lucas. So you know the Lucas, okay. So so I wouldn't just pronounce him dead as just stop the CPR as usual. Don't stop the pronouncing. I've done that, and somebody here took him about 3 hours to go from like 27 to 30. It was like very difficult. Okay, that's that. There's tons of preliminary reports and experiment. I'm just showing you the building blocks that actually started in this calamity that's called the therapeutic hypothermia that we did and then stopped after 10 years of doing. It wasn't like completely unreasonable to do, but in the same time, the literature wasn't that strong. There was a lot of pieces of literature, but there's not one piece that says, that's it, that's what you do. In the 1930s, there were first reports of successful resuscitation of cold water drowning victims with asphyxia, and that came from Russia. In the 1940s, the first report of using therapeutic hypothermia, using it medically to treat patients with traumatic brain injury. Dempsey in 1987 published that moderate hypothermia reduces post-ischemic edema development and leukotriene production. Cammers took that further in 2000 and tried to do this on stroke patients, 17 of them, and he failed. He just brought them down to 35 degrees. 35 degrees is nothing, and failed to show benefit. Hickey in 2000 published that he noticed in rats after asphyxial cardiac arrest that they become hypothermic. They make themselves cold, and he called that the nature's gold standard for neuroprotection. All right, this is Professor Negrovsky, right? Negrovsky is the father of reanimology. Okay, somebody can't fix it on the screen too. It's not only me. so Negrovsky is the father of reanimology. Reanimology is a science of cooling people down and warming them up. Cooling people down and warming them up. And he started actually with the hypothermia protocol for aortic arch surgery. Aortic arch surgery is one of those surgeries that is advanced so much in the last few years, but in the 60s there was a huge incidence of strokes, because what they would do, they will actually connect the heart and do the cardiopulmonary bypass as usual, but when it comes to cutting this piece and exchanging it, there's no circulation. They arrest the circulation completely, and the surgeon quick, and then they start the circulation again. During that time, the patients will have stroke. So it's very prohibitive. What he did is that they reduced the temperature less than 25, like really very low in the 20s. Put ice around their head, put ice around their whole body, and just like really cooled the patient so much down that that protected their brain, and the incidence of stroke was less. Obviously now they do shunts and stuff like that, but at that time it was amazing. And I saw when I was like I think when I was like 11 or 12, I saw a video of that. As a wonder of the world. In Russia they do that, and it's like the table in the OR just have like sides, and they like pour ice on the patient and pour ice around his head. And obviously dangerous situation when you do cautery and stuff like that. It's weird stuff, but they protected the patient, and he went further and stuff like that. And that science didn't cross, because at that time, the Cold War, so that science from Russia did not really make it to the Western part as much. People heard about it but never applied it. Negrovsky in 1988. That's after the Cold War, I guess. In critical care medicine, published the post-resuscitation disease, which is basically a disease that is not well defined, and we still know that these patients come to us look like sepsis, looks like SIRS. I don't know what it is, but they look very sick, and then the next morning is fine. And we don't know what it is. It's probably related to some endotoxins that we don't know what they are, and we
Yes, hold on 1 second.
profound hypothermia improves the Yeah, so basically, to prove, we're gonna jump in time now, from Negrovsky, we're gonna jump in time to 2009 and say, okay, how did this Negrovsky idea or the very low temperature work? So this is just a mediator, intracellular mediator after another that actually all become inhibited on temperature less with temperatures less than 25. So they like something called bad. Anything that is called bad is bad. I'm assuming, right? You know, so the mediator bad is inhibited. Capsase 3 is inhibited. BD2 is inhibited. All of these mediators were discovered that they code for apoptosis. So when you cool them down that much, there's no more apoptosis. You know, the cell is not gonna die, but it's gonna be cold. All right, so that's to prove Negrovsky theory. Let's go back to the real world now. When did this protocol for hypothermia started for after cardiac arrest? The credit should go to this guy. This is Bernard from Australia. He's an ER physician who in 1997 published published a study he did 22 patients of cardiac arrest and compared them to 22 historic control. And it was all comers, everybody will cool you after cardiac arrest. And he found that favorable neurologic outcome happened in 11 out of 22 versus 3 out of 22. And mortality decreased from 10 out of 22 from previously was 17 out of 22. So, you know, so he published it in the Journal of American College of Emergency Physicians, and nobody heard about it. You know, it's 22 patients, the guy's from Australia. What is this journal? I don't know. All right. So hypothermia after cardiac arrest, that's the phase 2 trial, if you will. The Americans are usually more practical than other people in the world, and this is the phase 2 trial, just to see if it works. So they took 9 patients, and 3 of them survived, by the way. So hypothermia was feasible without complication. They found that the average time from ACLS to initiation of cooling was about 74 minutes. And by the way, that's 2001. Until now, that's about the average time too. You know, it didn't change that much. ER presentation to initiation of cooling was 46 minutes. And the initiation of cooling to goal temperature was reached in about 5 hours. So that's why they came up with the number 6 hours. You have to achieve the temperature within 6 hours. And all patients, a very important statement here, all patients had rebound hyperthermia, 38 degrees. Also was a statement that made another 3 or 4 studies in the lab on animals. They found that animals who actually had hypothermia versus the animal didn't have hypothermia or didn't get hypothermia, and the animals that had rebound hyperthermia after hypothermia, they all had the same, the people who had the animals who had hyperthermia had the same injury as the animals who did not get hypothermia from the start. So if you think about it, the concept at least is that there is fire coming. You know, after you have a cardiac arrest, you have an oxygen brain injury, the primary injury. The secondary injury is when the blood comes in. That's called reperfusion injury. When the reperfusion injury coming with warm blood, free radicals starts to form and injure another wider area around the primary area. That I call that the fire, right? The thunderstorm, the fire is coming. Put ice on that fire, cool it down, then things are not happening, right? If you're an idiot and you warm it so quickly after, then it's gonna happen, but 2 days later. So just warm slowly until the cells can deal with it. All right, so in 2001, the only study that was done on therapeutic hypothermia and closed head injury, they did about 400 patients, it failed, and nobody's doing it anymore. And nobody knows why it failed. They say maybe it's because it causes bleeding in some areas versus whatever. So nobody's talking about this anymore. This is the big one. This is the big one that everybody knows, and that's what thrust the thing into the practice, which is a randomized multicenter trial in 9 European countries with blinded assessment to the outcome. They only used 270 patients, randomly assigned to normal thermia versus hypothermia group. This is the inclusion criteria. This is where the important part of this study, because really they chose la creme de la creme, like the best cardiac arrest patient you can ever imagine. Witnessed cardiac arrest. Initial rhythm is VFib or non-perfusing VTAC. They said we don't want asystole or PAA because they're horrible outcomes. 18 to 75 years of age. 5 to 10 minutes from collapse to EMT resuscitation. So they didn't actually include people who were like immediately resuscitated in the hospital or in the ambulance because that's unfair. And they didn't include people who the ambulance took more than 15 minutes to arrive in the scene because that's also be like also unfair. Less than 60 minutes from collapse to RASC. That's what I'm saying. Codes above 60 minutes is nonsense. And then unconsciousness, which basically they identified as no response to verbal commands. So not like this. I'm going for the tube. No, you have to say, "Hey, how are you? Who are you?" Say his name, and then he wakes up, or squeeze my hand. Some response to verbal commands. That's the definition of unconsciousness. That's the definition of unconsciousness we use all the time now, since that study. So you can see that they are very, very selective. Also excluded if the patient comes already cold, has coma already, pregnancy. They excluded even patients who are hypotensive for more than 30 minutes after RASC, which is all of them. Right? Excluded hypoxia for more than 15 minutes, terminal illness, typical follow-up coagulopathy, and another study, involved in another study. The goals was to achieve temperature 32 to 34 within 4 degrees of RASC using an external cooling device called Theracool. If more than 4 hours pass, use ice packs. Maintain temperature for 24 hours and passive rewarming for 8 hours. They use fentanyl, Versed, and pancuronium, which is idiotic. They're all very, very long acting. Primary endpoint was neurologic outcome based on the Pennsylvania Cerebral Performance Category. Oh, sorry, Pittsburgh. Okay, one of them.
That's it. 50-50.
Yeah, if you say Philadelphia, it would be 50-50.
There's not like a Lancaster cerebral performance category.
That is the best cerebral performance category available to us now in research, right? So they have 3 primary outcomes. The first primary outcome was death, mortality. Second primary outcome was cerebral performance category scale. They considered 1 and 2 are good outcomes. And then they had a third primary outcome, which is a weird way of doing it, but they put all the complications that could happen from hypothermia in a bag, and they call it all of this in a week. We're gonna look at those complications, and we consider those a primary outcome also. So they looked at 3,500 patients. 3,200 of them did not meet inclusion criteria. Unbelievable. And then they, at the end, 137 for the hypothermia group and 138 for the normothermia group. For the hypothermia group, it was discontinued, the hypothermia, for 6 patients for death, 3 for arrhythmia, hemodynamic instability, 2 for technical problems, 1 for liver rupture, 1 for primary randomization, 1 in error and cooling, and 1 lost follow-up. In normothermia group...
Who gets lost in follow-up?
No, he left. 6 months follow-up. So after he got the shot, no, he didn't walk out. They opened the tomb and they find there's nobody. They opened the door and nobody's there.
Somewhere out there is a vampire walking around.
So normothermia group, 138 patients. In that group they found more diabetes mellitus, more coronary artery disease, and more bystander CPR. So kind of equalizing each other. More sick, but also more bystander CPR. But that tells you that the table 1 in the study, they're not equal. The groups are not equal. There's some, the randomization wasn't successful, right? Because there's difference. All right, the results, target temperature was reached after 8 hours. So 4 to 16 hours, the range. So, and 70% of patients needed ice, and target temperature was never achieved in 19 patients. So, result or conclusion: do not use the Theracool. It's a horrible device. Maintenance for 24 hours was okay, and rewarming was okay. These are the results. They found death decreased from 55 to 41%, and the favorable neurologic outcome improved from 39 to 55%. Numbers needed to treat to prevent 1 unfavorable neurologic outcome was 6. Number needed to treat to prevent 1 death was 7. And numbers needed to harm to cause pneumonia was 14. And numbers needed to harm to cause an episode of sepsis was 16. Total number of complications in the first 7 days was bleeding, pneumonia, sepsis, pancreatitis, renal failure, pulmonary edema, seizure, arrhythmia, pressure sores. All of those are complications of hypothermia, and they were 22% higher, but not statistically significant difference. So obviously made a big deal, and then of course the limitations, we know the limitations of the study, only 8% of the screened patients were enrolled, exclusion of hypotension, all of the stuff that we talked about, and it doesn't mention anything about blood pressure management. They didn't standardize the blood pressure management. The Mass General Stroke Service believes so much in these people actually having a blood pressure similar to the strokes, like stroke. Like high blood, when we used to use their protocol, we used to we modified their protocol, and we actually used the map of 90 for all of those people. And their population was younger than our population here in the United States. So, proposed mechanisms. Each one of those mechanisms was done by a study, right? But when you see something that has 13 proposed mechanisms, you know that we don't know what we're talking about, right? Nobody knows how it works. But you know, there's things that make sense, like basically reducing metabolic demand by 6% at every degree Celsius down, reducing proteolysis, and protection of the fluidity of lipoprotein membranes, inhibiting the spreading depolarization, which is almost the same thing as decrease the excitotoxic damage by glutamine. Same thing. Glutamine is the most common and most common widespread excitatory mediator in the brain and the spinal cord. So if you decrease the production of glutamine and increase the uptake and all this, it will actually decrease the excitation that happens, the myoclonus that you see happening for those patients. That's from glutamine. Reduction of lactate production and tissue acidosis, reduction of free radicals, altering apoptosis, neuronal blah blah blah. Prevention of the disruption of blood-brain barrier and decreasing cerebral autoregulation, or preservation of the cerebral autoregulation. This is a study that was done in Pittsburgh. Okay, in Pittsburgh Children's Hospital, and they actually did a study on kids for hypothermia, and they failed clinically, and they showed no difference. But just to tickle your brain, basically on the first 3 days, they took the CSF and they did what they call antioxidant reserve, like putting peroxide radicals on it and finding if the CSF is able to scavenge peroxide radicals to what level. And they found there's higher ability of the hypothermia CSF to scavenge those free oxygen radicals than the normothermia CSF. And also they found the level of glutathione is higher, which is saying the same thing basically. Australia comes again. This is Bernard again, the same guy that we started with. After this, in 2002, February 2002, we published the Austrian study. Then Australian study published in November, I think, in 2002 also. He was also overshadowed by the other study. He's a very unlucky guy. But he published in New England Journal of Medicine. It was 4 Australian hospitals, but 64 patients only. Oh, sorry, 164 patients. And they had the hypothermia group was actually sicker. Less cardiac index, high systemic vascular, more hyperglycemia, but still have pronounced results, also 68 deaths, and went down to 51%, and then 26% neurologic outcome, with 49% from before. The advantage of this study that is actually all comers. It wasn't like VFib and VTAC was everybody. So that's advantage over the other one, was a little smaller. So the ILCOR had to happen, which is the International Liaison Council on Resuscitation. This council is basically, these are all the heart associations that, this is like the South African Resuscitation Council. This is the American Heart Association. This is the New Zealand, Australian, Japanese, Hispanic, all of these things, right? So they all met, I don't know where, but it probably was in a bar somewhere. I'm just joking. But they published in Circulation and said, unconscious adult patients with spontaneous circulation after out-of-hospital cardiac arrest should be cooled to 32 to 34 for 12 to 24 hours when the initial rhythm is VFib, right? What is VTAC? They forgot about VTAC. But such cooling may be also beneficial at other rhythms or in hospital cardiac arrest. So everything else, all other types, so only they selected VFib only, and they said, you know, whatever, only out of hospital, but everything else in hospital, VFib, whatever, Asystole, you can do it, but level 4 evidence. Then also they said, until further research, therapeutic hypotension should not be used in severe cardiogenic shock, life-threatening arrhythmia, pregnancy, or primary coagulopathy. Right? So if you have a hemophilia or whatever, or you have a liver disease, and maybe I don't know if they consider that primary coagulopathy, but your INR is very high, don't use therapeutic hypothermia because you're gonna bleed. But because they are heart associations, because guidelines are cooked, thrombolytic therapy doesn't preclude the use of therapeutic hypothermia. It doesn't make any sense, right? If you're worried about bleeding from therapeutic hypothermia, don't use it. And by the way, just to tell you, bleeding in therapeutic hypothermia is overrated. It doesn't happen that much. It's very mild coagulopathy. Target temperature should be achieved within 4 to 6 hours, but the sooner the better based on animal data. It's weird because some cardiologists would actually insist on not having anything to do with the therapeutic hypothermia in the cath lab. Like, man, you do it in ICU. Don't want any equipment or any, interference with in the cath lab because God forbid we'll lose a minute on door to balloon time or something. So we have to, do that later. And their defense is that the literature says 6 hours. Yeah, the literature says 6 hours because that's what they came up with. They said, okay, 6 hours so everybody can be able to achieve it. But the sooner, definitely, the sooner the better. Without, you don't need to give me a study, but even animal studies show that the sooner the better. It makes sense. And tailored decision for individual pediatric patient. By the way, despite having a lot of failures in the pediatric arena for therapeutic hypothermia, Boston Children does it all the time. It's the only thing they do for babies who are born, in cardiac arrest and had a risk of CP and stuff like that. The AHA, I think, when they sobered, they came out, or they maybe were forced to come up with the other recommendation. They said, we're going to do another recommendation, other set of recommendations published in 2005, just to make the American physicians understand it. So they basically put it in terms that we understand. They basically said, RASC in out of hospital and in hospital VFib. So they added in hospital VFib without any study showing anything about in hospital VFib. But they still forgot the VTAC. Anyway, class 2A recommendation reasonable to perform. And therapeutic hypothermia after all non-VFibs, this class 2B recommendation may be considered. So the language is very obvious. It's not 1A, meaning it's not a standard of care. Never been a standard of care. But at some point, the Wall Street Journal made it a standard of care, not a medical journal. Here I was begging for the Arctic Sun for years, and we were doing everything manually for cooling, and I was told I was never gonna buy and then I'm not exaggerating. I actually came one day. They said the Arctic Sun is here. I said, what Arctic Sun? They said the CEO bought it, or they like he had somebody buy it. Without me knowing that they gotta buy the Arctic Sun. And when I dug up, I found that there was he was made aware of he was made aware of that's like the old CEO. He was made aware of the Wall Street Journal article with patients that survived and crying and stuff like that. And people, the public went crazy. All right, so I mean, it was so prevalent at that time after this that people would ask you, like, people who read the newspaper every once in a while, they will say, why didn't you cool my father? And we'll be like, oops, that's an oops moment. What do I say? Like it doesn't meet criteria. They don't understand that. All right. So in 2009, there's an article that I love very much because I could remove this, whatever hospital it is, and put our hospital's name here, and it'll be exactly the same results. That's exactly. I've done every case of hypothermia here in this hospital that was ever done because I was here all the time, and so I know. Kind of know. I don't have the tally in front of me, but I know what happened to those people, and I see the difficulties, and they met exactly the difficulties that we had, similar. So it's a retrospective review, before and after comparison in a single center hospital, period of time is 2 years before and after implementation. And what they found, that the Redis therapeutic hypothermia survival was better in VFib and VTAC, and also better for febrile neurologic outcome in VFib and VTAC, and that was actually significant, statistically significant. In PA and asystole, it's still better, but not statistically significant. And that's exactly what everybody notices. Okay, what is this? What are we doing for PA and asystole? It's really bad outcomes. The authors also noticed that if they have a device, they have a more precise cooling and warming. If they don't have a device, then you can achieve the temperature faster. By the way, manually, I can achieve temperature faster manually, but you can't stop it. We'll go down below 30 and it'll be like stuff like that. They used the esophageal temperature probe. We did that from the beginning because we refused to use the Foley probe that the study used, because what if we need the bladder irrigation, So esophageal probe. Only 4 out of 170 had developed any infection or GI bleeding. So again, same thing. We didn't notice a lot of infection and GI bleeding. And then this is a depressing part here. In-hospital VFib. This is the only study that actually looks at in-hospital VFib. Had the same outcome. There's no improvement with hypothermia. Not because hypothermia doesn't work for these people. Just because if you're in the hospital with another disease and then have AFib on top of it, your comorbidities, your mortality rate is huge, right? So it's not because of that. It's just because the comorbidities. And same thing for PA and asystole, by the way. The comorbidities is what's killing you, not the. Recent work, this guy came in and was a predictor. This actually has been debunked, but. In 1993 was published that delaying and cooling negates the benefit of therapeutic hypothermia in dogs. Abella, remember that name? Abella is a famous name in hypothermia. Intra-arrest cooling, basically cooling during the cardiac arrest. And if obviously you know that therapeutic hypothermia is under attack now, and it's not happening the way we did it before in the past. I'll explain why. But if hypothermia comes back, and we ever do hypothermia again, it's going to be because of this, right? If we start doing intra-arrest cooling, because it makes sense. If you cool the patient immediately during the cardiac arrest, you don't have a chance to have the injury that would happen with the secondary outcomes, or decreasing the chance. But of course, it needs practicality here. You have somebody with a cardiac arrest, don't know if he's going to recover or not. There'll be 2 teams working on the patient. One is doing the CPR, and the other one is doing the catheter that goes in the groin, and it has a elongated balloon and continuous flow of cold saline in it. Boddicker published that hypothermia improves defibrillation success. So if you're cold, your defibrillation is. We see that in the cardiac OR all the time. In Australia, what they did, and then actually in some towns here in Massachusetts, they actually had 2 liters of saline in the ambulances, iced saline. So when somebody has a cardiac arrest, they give it to them in the ambulance to start the cooling early. I was in a lecture about this, and I saw a photo of somebody arrested in an Australian a market, marketplace. What do you call it? Supermarket, and they couldn't find ice, so they put all the frozen peas and carrots and everything. They put them in a shopping cart and filled them with this and ran with them to the ambulance or outside the door or something like this. And took a picture of it. All right. So let's stop here for a second and tell you what is newer than this. I didn't put it in the presentation because I got depressed. So as I was in my way to buy new Arctic Suns, right? We had 2, and now they broke, so we need to, or they're old, so we need to buy new ones. It was about 2013, and we're negotiating, blah blah blah. And then a study came out from Dr. Nielsen. That's another name that you need to remember in therapeutic hypothermia. Is from Sweden, and he noticed obviously that the patients in the original study with normothermia group, all of them had fever. Some sort of fever, right? So he said, if we maybe the fever is what killed the patients, not the actual hypothermia in one group and normothermia in another group. So he decided to do a study where he uses 33 versus 36 degrees and see what's the difference, what can cause what. And he found that the 36 and 33 are equal. There's no difference between 33 and 36 degrees. So he concluded that probably 36 prevents fever, and that's what happened. You know, that the fever is what decreased the outcome, worsened the outcome. So I was ready, you know, to have the study like massacred. We discussed it in a journal club, just so you know the atmosphere of the journal club. I stay there like a pit bull. I don't know the study. I'm just like you say something and I jump, you know, and tear you apart in front of people. It's done in front of the whole hospital. I'm serious. He knows. Yes. Anyway, so I was ready to tear this apart. I couldn't. The study was perfect. You know, it's 800 patients. The other study is 200 patients, 270. The two groups are equal. The two groups here were not equal. It was all comers. This one was VFib and VTAC, right? I looked in the study. Said maybe they have more time to, you know, like they took more time to achieve RASC, because you know if you're 60 minutes average, then nobody's gonna recover. You know, so it's gonna be no difference. I found that they actually took average 20 minutes for to bring the patients back. So there's no way that you can argue with a study like this. And you know me, I mean, I would not, like, if something makes sense physiologically, and I just made you a point to prove that therapeutic. I was going around giving this lecture to people, you know, and I wasted really six years of my life studying everything that I need to know about hypothermia, and then I found that it doesn't work, or they told me that it doesn't work. So in any case, I would not have stopped it unless it's expensive, you know? Like if you come from here till tomorrow, tell me every day there's a study that is published, every day, that cranberry doesn't work for CAUTI, I'm still gonna use cranberry. It's a goddamn cranberry, right? But you tell me about therapeutic hypothermia, which requires a machine, requires, you know, nursing care for 3 days, you know, 1-to-1 and very intense and complications, stuff like that. No, then we should not continue. The cardiologists had a problem with it, right? They're saying, well, we had our society did not change the recommendation yet. I don't care. That's why we read literature. The society reads literature and wait 10 years and then come up with recommendations. Here, we read, you know, as soon as something comes up, if it's convincing, we change. So we changed, and it was a big turmoil both times. When we started was turmoil. When we changed was turmoil and fights, because, you know, why would we change? People were anxious both times that we changed to 36 degrees. And you know, watching those patients, you know, I'm just re-evaluating my whole practice again. I don't know. It's really very, very confusing, because I also noticed, like they noticed. Huh? Remember, they said 6 only died. Remember in the study I showed you, hypothermia patient, it was stopped for 6 for death. That's 6 out of 127 patients, right? In my experience, there's only 1 patient that arrested when he was hypothermic, in a span of like 8 years or so, or 6 years. Huh? That's a lot of patients too. And I asked around, and I told somebody in a conference, he said, that's a valuable information. If you can't capture it, please send it to us. And I said, I can't capture anything. You know, these things happen 2 computer systems ago. We changed computers a million times. We can't get this data anymore, unfortunately. But I can tell you, you can ask any nurse, have you ever seen any one of those patients that are hypothermic? They might have a severe anoxic brain injury, and we do see CMO later, right? I'm not so sure about that, but all I'm sure about is that they don't have the second cardiac arrest. Right now, they do have the second cardiac arrest. Right? When you don't cool them, it's like, he's gonna arrest again tonight. He's gonna arrest again tonight, and he arrests. You know, very common that you see the second cardiac arrest. So I don't know what cooling does, but it improves your blood pressure, or maybe decreases the oxygen requirements or whatever. That the heart itself doesn't arrest the second time. So I'm very mixed, and now a lot of people are mixed too, and they're saying, okay, there is therapeutic hypothermia, and there is targeted temperature control. When they say therapeutic hypothermia, we mean 33. When we say targeted temperature control, we mean 36. So the therapeutic hypothermia is not completely dead. So I went from no 33 at all, always 36, to I'm starting now to select some of the patients, and I'm learning more as I go, which patients I actually make them 33 as opposed to 36. And I came up with an idea. It's basically the patients who are hypotensive, very hypotensive, like after cardiac arrest, they're on 60 mics of levofed and 20 mics of epinephrine. It's very difficult to maintain them and stuff like that. These are the ones that we're gonna call to 33, so they don't have the second cardiac arrest. It give them another chance, and also decreases the use of pressors, because therapeutic hypothermia is a pressor, right? So we'll talk about that in a second. All right, pediatric hypothermia, that's adult. So we're talking pediatrics, just one slide. Anoxic brain injury, increased intracranial, didn't work none of that, but they still use it. They extrapolated from adult literature, and now they don't want to move. It's like, that's the only thing we can do. This kid is gonna be, a math, cripple for the rest of his life. Let's just continue to cool him, That's fine. I don't have a problem with that. This is my second favorite study in this, which is basically a study that was done in acute liver failure. Acute liver failure is one of those things that we can't do a lot for. It's like, should we give him NAC? Should we give him steroids? And everybody, comes and qualified NAC and steroids for us, and then we end up doing nothing, watching the patient die. So this is actually done where they actually cool the patient with therapeutic hypothermia, cool the patients that are developing. There's a patient that was here like a few days ago. The family insisted on him going to another tertiary care center. I had this planned for him, but I said, okay, send him there, and he's CMO now. But in any case,
The young guy?
yeah,
You're serious?
yeah, CMO.
Oh man, that's really
So
sad.
it's just like Anyway, so what is the causes of death for therapeutic hypothermia for liver failure, acute liver failure?
Coagulopathy,
Coagulopathy.
cerebral edema.
Yeah, coagulopathy infection, that's number 1 and 2, and then cerebral edema number 3. Right, so they die of cerebral edema because of the ammonia, right? Very high ammonia, they swell, blah, blah, blah. So if you decrease the ammonia, therapeutic hypothermia, decrease arterial concentration of ammonia, decrease brain concentration of ammonia, decrease proteolysis, decrease renal release. Therapeutic hypothermia preserve the prevention of brain lactate and alanine accumulation, and prevention of the changes of brain organic osmolytes. The brain extracellular space, decreased accumulation of glutamine again, and decreased glutamine-induced astrocyte swelling, and improving hemodynamics, improving glucose metabolism, decreasing inflammation. All of that's done by hypothermia. The hemodynamics, you have to stop on it a little bit. The hemodynamics for patients with liver failure, they have all the shunts to start to develop, and they have a very hyperdynamic circulation. Very high cardiac output, increasing the CBF will increase the intracranial pressure. Right? So that actually reduces that CBF. All right, the trials that were done, these are all the trials that were done by the same person in Europe. And they're all mostly acetaminophen toxicity, right? So, and a small number of patients, 7, 9, 5, 5, and 14 patients, and these are the number of acetaminophen in them. Most of them is the Tylenol. Duration of cooling, he started shy, and then went up all the way to 118 hours, which is like 4 days or something. Goal temperature, same goal temperature, 32 to 34. End point, decreasing the ICP and waiting for organ transplant, or successfully waiting for organ transplant. The last study, for example, 13 out of the 14 survived. Will be interesting to see if those 13 or there's one from the other side. But 13 out of them survived to organ transplant. 10 of them survived for 3 months, waiting for the organ. So basically, when you die from it, you die in the first 5 days. So those patients, obviously liver is not going to be available in 5 days, So if you make them survive during 5 days and then warm them up, they might survive up to 3 months to wait for organ transplant. So that's an achievement, and you're never going to see a study bigger than that. So.
I thought that was my name.
We're talking about you. So anyway, so that's huge, and one of our friends here, one of our your previous colleagues, is now attending in Vienna, and he's done that. He called me and said, GI attending actually. He said, I've done it. I've done therapeutic hypothermia and somebody and survived. Obviously it's one patient, but 1 and 2 and 3 and add to the 13. I think it has some role in it, especially in the field that we don't have nothing to do for those patients. So think about it. Therapeutics of hypothermia and stroke. The Stroke Therapy Academy Industry Roundtable in 2006 called therapeutic hypothermia the most promising potential modes of neuroprotection. They call it the gold standard. And when I came here, the neurologist asked me, "Are you gonna buy the helmet?" I said, "What helmet?" He said, "There's a helmet we put on the patient with a stroke." Nobody does that anymore. They did studies for cooling for therapeutic hypothermia for ischemic strokes, and they failed. They did for subarachnoid hemorrhage, and they failed. And the only one that has some success is the IHAS trial, which is intraoperative hypothermia for aneurysm surgery. This is obviously this very delicate surgery, and everybody's like holding their breath because if they touch the aneurysm, they don't see anything. And they may need to just close the skull and call it quits. Yeah. Hypothermia might actually protect the brain until they can do something. There's 2 studies that are going on. It's been going on for years, actually. Maybe soon we'll have some. This study, ICT, blah, blah, that's actually hypothermia and thrombolysis, and one in Europe also, hypothermia and thrombolysis. So combining hypothermia with thrombolysis. There's a neuro-intensivist in New York who actually does a weird thing. He actually, still until now, cools his patients with stroke using an Arctic sun. And they're awake. So really intense cooling, right? But then put a bear hugger on them. So the Arctic sun is much stronger than the bear hugger. It gives you like core temperature drops so much. But the bear hugger at a low rate, it only makes sure that the skin receptors who actually start the shivering process are warm. So you don't shiver, but you're cold inside, like 34 degrees, but the skin is warm. Yeah.
Sounds pretty weird.
Exactly. All right. Therapeutic hypothermia and spinal cord injury. Spinal cord injury, you're never going to see a phase 3 trial. I wish we can, but I'm very pessimistic about having a phase 3 trial on spinal cord injury. It's never going to happen. But these studies were done as phase 2 trials showing that it's feasible, it's done, blah, blah, blah. So right now, it is per preference of the neurosurgeon, right? So one of my friends had a friend who actually broke his neck in Narragansett Bay, and the chopper came in, put him in the thing, took him out and put him in a bucket of ice, because the surgeon in that hospital said put him in a bucket of ice. So it depends on the surgeon. I think if you're in the field or something happened, I think cool those patients, because that's the only thing you can do for them.
They do it with like NFL players.
They
Get
cool them.
spinal cord injuries, yeah.
So I think it's a good idea. I think that's the only thing you can do. We used to give 2 grams of solimedrol for those patients, and it shows no difference. I still think it works, but it shows no difference, so nobody can give it. But cooling is easy, you can do it. When I was at Mass General, Dr. Davison, who's a very famous anesthesiologist, and Dr. Cambria, who's a world-renowned vascular surgeon, they had a protocol. They created a protocol for thoracic aortic aneurysm repair. So Mass General used to be I think, the referral center for thoracic surgery, thoracic aortic aneurysm. So they come from everywhere in the world. And what's the problem with thoracic aortic aneurysm when you do a clamp very high up like this? Is that you're gonna block you're gonna no flow in the anterior spinal artery, the artery of Adamaquix. And in order to prevent paraplegia, they put basically a spinal catheter. So they touch the spine in 3 areas. They put a thoracic epidural first, and then they put a spinal catheter in the lumbar area to drain the spinal fluid, and then a little bit above it, still in the lumbar area, they put a pediatric swan in like a swan that you use for kids. They put it inside the spinal cord, and they use the pediatric swan to measure the temperature. That's the only reason you put the swan there. And they use the lumbar axis to drain fluid, and then of course the epidural for pain. So what they do is that they cool the spinal cord to like 10 degrees Celsius, like freeze it, and also drain fluid from the spinal cord around it, because the spinal cord has the same thing, like, you know how the CPP equal MAP minus ICP? The spinal cord perfusion equal MAP minus spinal cord pressure. So if you decrease the spinal cord pressure, you have more MAP, you have more perfusion. So they would do that, and patients don't have like, really. I've seen only one case would actually get paralyzed, and another case actually. That's thoracic. I've seen another case which is very interesting. I've seen another case with aortic, abdominal aortic aneurysm, not thoracic, but high up. So apparently his artery come from lower down or something, and in the ICU he's fine. Suddenly he's not moving his legs. So we call the surgeon. We're gonna have to do the lumbar catheter, maybe take him to the OR. I don't know, blah blah blah. And then by the time the surgeon comes, I put him on neo, blood pressure, intentionally up to like 190, 200, and the patient regained his function. And we kept him on this for a few days, and then.
And then his aneurysm ruptured.
No. Dun, dun. Okay, hypothermia and pharmacokinetics. Basically, all of the medications are delayed in their metabolism, roughly by 25%, except morphine. Morphine has decreased affinity to delayed metabolism, but decreased affinity to mu receptor. So you have to 5 times increase the morphine dose by 5 times. Complications: prolonged QTC, arrhythmia, reduced contractility, hypertension or hypotension. Immunosuppression, leukopenia, impaired WBC migration, decreased phagocytic activity, and reduced bacterial clearance. That's why you're having some infections. Thrombocytopenia, mild coagulopathy. That's why you have some, coagulopathy. Hypokalemia, hypomagnesemia, hyperglycemia, and cold-induced diuresis. We talked about cold-induced diuresis. Hyperglycemia, we talked about how the insulin is getting, deactivated. Now, these are important: hypokalemia and hypomagnesemia. When the temperature goes down, the potassium and magnesium goes down with it. When the temperature goes up, the potassium and magnesium goes up. So if you have somebody with hypothermia coming to your ER, for example, and you want to warm him, and his potassium is 3.4, don't give him. It's gonna get high. Also, when you warm those patients, they drop their blood pressure, because you're basically dilating the blood vessels, right? And you have to put about a liter for every degree Celsius that you give. You dilate, you give a liter. Dilate, give a liter. Every degree Celsius. So you have to be ready. If the patient is not ready to be, if they're already on pressors, high dose pressure, don't warm him. There's no rush. As long as it's above 30, there's no rush. Right? Shivering and cold burns and stuff like that. We had a very, very interesting case about hypokalemia, and it speaks for where the potassium is, right? So we had somebody, I'll save you the details. He stayed hypothermic for 7 days because he arrested 2 times. Anyway, so the last time as we were warming him up, young guy, as we warmed him up, he arrested again. It's like, how are we gonna get him off the hypothermia? It's like, we warm him up, he arrests. So it must be the potassium. So the potassium was high, his renal failure, and he also received a lot of insulin. His insulin was like 400 units an hour for a long time, and the insulin put the potassium inside the cells because it's so much of it, and we had to replete the potassium at that time because the potassium was 1.8. So we gave him tons of potassium, and then when we were trying to get rid of warm him up, the potassium is coming back from the cells to haunt us. So he's on dialysis, blah blah blah, and then we warm him. He had a cardiac arrest. So he said the next time we will warm him up on dialysis. So we obviously before dialysis the next day, what are we doing? Bicarb drip, hyperventilation, insulin drip, all of the things to put the potassium in the cells until he survives till tomorrow. Dialysis comes, we start warming during dialysis, and then after dialysis we said, okay, let's continue warming, and his potassium is 6. We're measuring potassium, so we stopped the warming. So what is happening? And then we came up with the idea that potassium is not available for dialysis to be dialyzed, because we're putting it inside the cells, right? So the next day we actually, as dialysis starts, we stopped the bicarb drip, we hypoventilated him, and let the potassium rush out of the cells as the dialysis machine is sucking it out, and it worked, and he actually got extubated, and then whatever. Okay. All right. This is the industry. Theracool, we said we're not going to use it, right? That's the original study. Intercool, that's the thing that Dr. Abella uses, or similar device where they actually, I think they had it in BMC, where they put the catheter in the femoral area and they cool. I don't know if they still use it. Thermosuit. This is the thermosuit. I used to use it in another hospital where they actually, it works by a known convection forces, which is basically they do it in the ER all the time for patients with heat strokes. You sprinkle them with cold water and ice and put a fan on them. That's the best. So that does the same. It's like a float. It looks like a float, like the pool float that you. But from every aspect, you cover the patient completely. For 15 minutes, you're not going to see the patient. The patient is completely covered. And the EKG lead has to be covered with tegaderms and everything. And then it sprays water, cold water on the patient, and then current comes in and just dries the patient out, air current. And the patient goes from temperature 37 to 32 in 15 minutes. So it passes through the shivering thresholds very quickly, so you don't have to really paralyze the patients for this. And it's fast, and it could be a future also for this industry. But unfortunately, it is glitchy. It glitches a lot and has weight limits and stuff like that, so nobody uses it. The Arctic Sun is the Arctic Sun, obviously, it's radiolucent, and not only that, it gives you access for the groin and for the upper. And it actually, you can measure temperature, you can predict that the patient is having fever. That was one of the things that, criticized, people get criticized, why would you use it? I don't know when the patient is having fever. Yes, you do, because if the machine is working so hard, you can see that the machine is working so hard, that means the patient is having fever. This is our old protocol. And then we'll talk a little bit about EPR. EPR is what? Who's this? Safar, right? Peter Safar. He's I mentioned Peter Safar before. He's the father of the ICU, Pittsburgh Children's Hospital. He's the one that started rounding ICU, team. The ICU started in 1945, but it was for all. This one is like, okay, we have an ICU team that's gonna round and blah blah blah. He's the one that invented the CPR, right? Which is the famous scene where he actually took 10 medical students that volunteered to be paralyzed, and he gave them mouth to mouth until they were unparalyzed. I hope he gave them excellent in the course. I hope. That's crazy stuff. Anyway, he and Dr. Liam, is the guy also who showed up in a hospital in Philadelphia. I think I know a lot about Pennsylvania, more than I thought I knew. Still tasteless. Anyway, doesn't matter. So he showed up, his partner showed up in the hospital in Pennsylvania, first day as a doctor. And he found somebody he described it very, very vividly, somebody on the gurney, he's blue, he's, his drool, and he said to stop. He doesn't even have a badge. And he wiped the drool and gave him mouth to mouth, and the patient survived. So that's where the mouth to mouth is.
No.
The funny,
Let him go.
It's
Good run.
the city of brotherly love. That's why. That's
Let him go.
Brotherly love. So anyway, so this guy in the CPR original publication, which is only one paper, he said consider cooling the patients. He comes from Austria, probably heard about Nigrovsky, and he said consider cooling the patient in 1970. That's very old. And then before he died, he came up with something called the emergency preservation and resuscitation. He made the Safar Institute for Resuscitation, and he had an emergency. What is that? That's basically, they took 6 dogs, one after the other, obviously, and they cut their wrist, and they had let them bleed out until they died. And they did CPR on them, and after the CPR, they pronounced them dead, and left them for 1, up to 2, up to 3 hours, cold with ice saline. So they put ice saline on them, infused actually liters and liters of ice saline on them until the core temperature reached down to 4. Right? So they froze almost froze these dogs' temperature to 4 degrees Celsius, and nobody's doing anything for them. No CPR, nothing, just like sitting there. And then they took him to the OR, repaired the thing, and warmed them over days using cardiopulmonary bypass. And all of the dogs are alive and learning new tricks, right? So it just caused huge. They call it emergency preservation and resuscitation. This guy unfortunately died, and now Dr. Kochanik took over this project. And now, now they have approval from the FDA to do it on people who die in Maryland. So in some Maryland towns, you have an opt-out statement, right? So if you don't go to the town and opt out of the study, say, I don't want to be cooled when I'm dead, they potentially can cool you when you're dead.
So Pennsylvania's protecting you
From
being
that.
a part of that.
From that.
Weird.
When the
So-
zombies start coming up from Maryland.
Well, Maryland, that's gonna be yeah, exactly. I mean, imagine if they're hanging around from their legs and then they wake up.
Exactly.
Yeah. So this is gonna be something. I mean, they're doing it for soldiers on the field. They're probably not ready for 20 years. But somebody at some point is gonna be like, you die in Iraq, we're just gonna cool you. We're gonna put you in a box that is like a fridge. We're gonna ship you to Germany and then take our time to fix you or do whatever needs to be done. Right? It might be something in the future. I predicted the rise of the echo and ultrasound in ICU. I'm predicting maybe 20 years from now, you can spit on my grave then, that the ICUs will be 2 ICUs. I'm reporting today to work in the cold ICU. I'm reporting to work in the normal ICU. And people will be cold and stuff like that. It might be, I don't know. But it's chilling. It's really chilling, pun intended. When Dr. Koshanik comes in, I mean, I've never heard somebody say that before. Most researchers complain that they need more money, blah, blah, blah. This guy say, I have unlimited funds from the United States Army. Unlimited. I can spend billions of dollars on this research. He says that at the conference. That's amazing, right? That's amazing. And then last thing is crazy ideas. Don't try this at home. We do hypothermia here for hypoxic patients, and we do hypothermia for uncontrolled shock. So if you see one of those septic shock patients, we never had one disordination. But when we have someone that is really very intense shock, he's gonna die from can't control it with the pressors. We actually cool him, and he'll come off the levofed just within like few hours of being cold, just because. In my opinion, in our opinion, because we're partnering on that, in my opinion, that basically cooling is the best pressure. Because when you give somebody levofed, what does it constrict? It constricts the cutaneous blood vessels and the splanchnic blood vessels, right? When you cool somebody, it constricts what? Only the cutaneous blood vessels. It saves all the other organs. And not only that, it causes cold diuresis. So it's the best of the 2 worlds. The patient is on and peeing, right? So that's only as a rescue. And if you open this door, please, if you don't mind, open wide. Did anybody notice this huge poster over there? No, I don't think you guys don't notice this. It's a wallpaper. We made it huge because of that reason.
I saw it.
That one. What did it win? The first place in what in that conference?
At the University of Texas, Together Research Symposium.
Yeah, just a small conference for medical students. But he took our data. It's only the ones that we could find. We did it for like at least 30 patients or something. The one that we can find only 7 patients that we have complete data on, and he used an index that basically because we found it's difficult to actually do the research only on MAP, because the nurses are titrating the levofed and the MAP is always the same. Right, so we had to. He looked for something that he got from pediatric literature, where we actually map times the butamine dose times the levofed dose and some concoction to make it a score, and he found that basically the need for pressors is reduced with cooling, which is, I can tell you that before he did the study. We know it. Nephrologists, by the way, in outpatient dialysis centers, when they don't have levofed, what do when the patient drops the blood pressure? They cool the dialysate. Surgical ICU, when the AAA rolls in, or the gastric whatever rolls in, and he's cold, they don't warm the patient. They say warm the patient gradually so he doesn't drop the blood pressure. So all of these things we know from before, but this is something a ripe, area for research. All right. Any questions, professors? With emphasis on professors.
What about, I don't know.